Okay, now to today's speaker, I have the pleasure of introducing Dr. Brian David Robertson. Retired Colonel Brian Robertson is a sleep medicine physician and allergist immunologist and the Chief Medical Officer for Nightwear. He is an associate professor of pediatrics and medicine at USUHS, the Uniformed Services University of the Health Sciences. Dr. Robertson completed his undergraduate training at the University of Georgia and his MD at USUHS. He completed a residency in general pediatrics at Wilfred Hall Medical Center in San Antonio, Texas. He completed fellowship training in allergy immunology and sleep medicine at Walter Reed National Military Medical Center in Bethesda, Maryland. He has 25 years of service as a U.S. Army physician and has held multiple hospital and military medical leadership roles, including the U.S. Army allergy immunology consultant to the Surgeon General. He is also the former chief of the Sleep Disorder Center at Walter Reed National Military Medical Center. Dr. Robertson is involved with regional and national leadership in allergy, immunology, and sleep medicine. He is a board member of the Maryland Sleep Society and a fellow of the American College of Allergy, Asthma, and Immunology. He is the chair for the American Academy of Sleep Medicine's Pediatric Interscore Reliability Program. He lectures frequently on sleep medicine topics at regional and national levels. I now hand it over to the esteemed Dr. Robertson, who will be talking about sleep and nasal congestion.
Great. Thank you, Dr. Singh. And thank you all for joining me. We'll move through the slides. My goal is to be finish talking at 2:45, and then we'll have time for questions. So that's where I intend to go. So we'll get started. This is the CME disclosure and accreditation slide. As far as disclosures for me, I work for a company called Nightwear. It's a startup that treats nightmare disorders. It has nothing to do with what I'm going to be talking about today, which is mostly about nose things. But I won't be talking about nightmare disorders or that particular product. And I will be mentioning other products. And if I use brand names, I apologize. So don't hold that against me. It's a habit. But the drugs that I'll be talking about, several drugs in there, but I don't have any financial interest in those. These are our objectives, which are to understand the sleep problems that are a result of nasal congestion and nasal obstruction. We're going to talk about like anatomy and physiology of the nose, because I think it's really important, and especially as it relates to sleep. And then finally, how do we effectively treat nasal congestion so that your patients can use CPAP? I like to start this with a case. This is a case that was many years ago, but I really like this case. It's a fun one. This is an 11-year-old male I saw in the clinic. I was on active duty at the time, and his father had brought him in. This is not him, but his face looked a lot like this. So he had what's called an adenoidal face. And what do we mean by adenoidal face? The first is that his mouth is open. His nasolabial folds are kind of soft or even non-existent here. His philtrum, the space between the nose and the lips, is relatively long. He's got a little bit of lip lickers dermatitis, which could be one of two things. You breathe through your mouth a lot, and your lips get dry, so you lick them, and you're a kid. Or the other thing is it's winter and cold places, the air is very dry, and so you'll see a lot of kids with this lip lickers dermatitis problem. Kind of tired looking kid, but this is an adenoidal face. We'll come back to that later. So this young man, he's 11 years old. He complained about snoring and restless sleep. He had a lot of daytime sleepiness. On exam, he had tonsils that looked a lot like these. They weren't quite touching, but they were close, so they were 3+ tonsils. He also had a high arch palate, and for those of you who don't know what a high arch palate looks like, these are high arch palates. The one on the left is sort of, I would say, in the moderate range, and this one on the right is pretty severe. Why do I say that? If you look at I think we have some dentists on this call too, and you'll be familiar with this. You can see that the maxillary arch should be kind of rounded. And when you have a high arch palate like this, one thing that happens is that the maxillary arch gets to be a little bit triangular, and so that's a clue. This is a clue, and I look for it on almost every single mouth that I look at. I look for this problem because when I find it, it tells me that this person has been breathing through their mouth a lot. So this kid was memorable because as the parents was leaving, they were going to go eat lunch, and Dad said he's going to go inhale his food. And I said, "What do you mean?" And he said, "Well, like what he does, because he can't breathe through his nose, so he'll take a bite of food, then he'll kind of take a deep breath, chew it up and swallow it as fast as he can, and then start breathing again because he can't breathe through his nose. So this got my attention. This is why I remember this kid. We did a sleep study on him. He had moderate sleep apnea. We sent him for a rapid maxillary expansion and for tonsillectomy and adenoidectomy. I also sent him to allergy because there was some history that sounded like he had allergic rhinitis, which in fact he did. These are rapid maxillary expanders, if anybody's not familiar with them. And it's basically this little ratcheting device that is installed in the across the maxillary arch. And then there's a mechanism here where every day for several weeks, the parent will kind of turn that little crank and slowly push the maxillary arch apart. Okay. And it does a couple things. The hard palate is the roof of the mouth, but it's also the floor of the nose. And so it makes a little bit more space to breathe when you do this. And then, as I understand it from orthodontists that I've talked to, this is a helpful first step before you do some kind of a lot of braces. So, and again, I'll let some dentists weigh in on this because I'm definitely not a dentist. So this is an example, like kind of before and after. So before maxillary expansion, these teeth were about 12 millimeters apart, and now we've almost doubled that with the expander. After that ratcheting thing happens, then the rapid maxillary expander is left in place for a few months and then removed. And then if any orthodontic work needs to happen, that's when that occurs. So this child had his tonsillectomy and adenoidectomy and the rapid maxillary expander placed. And then we had repeated a sleep study, and it had almost normalized. We were really close to being an HI of less than 1, so we were pretty happy about that. He did have allergic rhinitis, and we started on immunotherapy to help decrease his nasal congestion problems. When I think about like obstructive sleep apnea, I think about 3 other diseases that go along with it. And these things kind of coexist and they influence each other. The first is cough. We call them the core diseases. So the cough, so asthma, obstructive sleep apnea, and then rhinitis, either allergic or non-allergic, and esophageal reflux. And when you have rhinitis, and we'll talk about this a little bit more, it tends to make obstructive sleep apnea worse because it obstructs the nose partially and makes it harder to breathe in. And you have to generate more negative intrathoracic pressure in order to breathe effectively. So this is part of upper airway resistance syndrome. And this other things happen too. When you have esophageal reflux, obstructive sleep apnea tends to make esophageal reflux worse. When you have esophageal reflux, you tend to do these little micro aspirations that make inflammation in the airway worse, so that can worsen asthma. And the esophageal reflux can also cause inflammation at the back of the nose and back of the and the oropharynx, and that further narrows that space that you have to breathe and can make sleep apnea worse. So all these things play into each other. And I think that's an important concept. When you see when I see one of these things, I need to ask about the other things. And it gets to be a habit after a while. So hopefully you can do that too. So there were some studies about like when you look at people with sleep apnea and kind of going back to the core disease, one of those core diseases is rhinitis. And so this was a study back in 2004 as a case control trial of patients that had sleep apnea. They used COPD patients as controls, and they were age and sex matched. And what they looked for was they looked at these patients with sleep apnea and compared them to the group with COPD to see who had allergies. And it turns out that if you have sleep apnea, there's a pretty strong association with having sensitization to really common perennial allergens like dust mites and dogs. And that was one of the findings here. This has been replicated. I will say that similar findings like this have been seen in other studies, but I like this study because it's really simple and straightforward. How does allergic rhinitis affect sleep? This is a nice review article. It was actually published, I guess 2 years ago now. But what they found, first of all, like allergic rhinitis is insanely common. The prevalence in some populations can be up to like 50%. It can be a really, really common thing. And if you add in rhinitis, like non-allergic rhinitis, it's even higher. 66% of patients with allergic rhinitis have some kind of sleep impairment. And the other thing is that, again, patients with allergic rhinitis have significantly higher odds of sleep apnea, sleep disordered breathing, snoring, and nocturnal enuresis. And it also seems that sleep dysfunction correlates with the severity of the allergic rhinitis. So, and I attest to this, like when I have patients in my allergy clinic that have really bad sleep allergies, one of the major issues they have is that they have trouble sleeping, especially when it's indoor allergens, things like dust mite allergy, animal allergy, if they live with an animal. Those are really important. Here we go. But there's other studies that show that the allergic rhinitis is, um, they've seen that there's elevated OSA risk with allergic rhinitis, but it doesn't seem to influence the severity of the OSA. So it's like it sets you up to get sleep apnea, but there's other things that are important with how severe your sleep apnea is, things like obesity and things we're used to thinking about as sleep doctors. Also, in children, the allergic rhinitis does not seem to influence the apnea-hypopnea index in children that have sleep disordered breathing. And that's another important point. So it's not a super straightforward connection, but there is a connection. So let's talk about the importance of the nose. So the noses are really important for doing several things. For normal breathing, they humidify the air, they warm the air up that we breathe, and they filter out the air that we're breathing too. And they're also, your nose is vitally important when you're using CPAP. This is one of my sons. This was taken in the winter. That's why he has his lip lickers dermatitis, because we could not stop him from licking his lips, and he didn't like with the not lip gloss, the chapstick. So we have a few structures that are really important with the nose. First, the ala nasi. It's the wing of ala is the word for wing. So your nose has two wings, the parts that cover your nostrils, and that's the ala nasi. There's this little fold fold in your skin. Let's see if I can. Can you see my mouse? I don't. After seeing.
Yeah, we can see your mouse.
You see the mouse? Okay. So this little fold of skin, good. Right here is called the alar nasal sulcus. When you have adenoidal face, that alar nasal sulcus tends to be kind of flattened out. Ian here, he does not have rhinitis, so he doesn't have adenoidal face, so he's okay there. And the philtrum is the space between the nose and the upper lip, that spot right there. And then finally, the anterior nares, our nostril. These are the important things there. There are four things that can happen with your nose. And so with the physiology of your nose and what it does for sleep that are important for sleep apnea. The first is, I'm going to explain this, is like, I don't know if you're familiar with the Starling resistor model. A lot of sleep doctors are. For those who aren't, I'll explain this very quickly. So the Starling resistor model consists of two rigid tubes structures and then a collapsible tube structure between them. And that collapsible tube structure in the middle is often conceived of as being in a box where you can control the pressure inside that box. So we have pressures in a certain amount of air pressure in the upper segment and in the lower segment, and then we have a certain amount of pressure in the intraluminal segment in that collapsible airway part of the tube. And then the pressure outside of that tube inside this box. And when you have nasal congestion, what happens is that when you try to breathe in, it's hard. And I call this like the clogged straw effect. So if you had a strawberry milkshake and you had a paper straw and you were sucking on your paper straw, you're happy and it was great, and then a strawberry gets stuck in the end of your straw, what happens to your paper straw? It collapses, right? And why does it collapse? Because you're sucking really hard on it and you're decreasing the intraluminal pressure of your straw, and it makes it collapse. And a similar thing happens when you have an obstructed nose, is that it is difficult to breathe through this structure, so you have to suck harder to breathe in air. And when you do that, it tends to lower the intraluminal pressure in that collapsible segment, and then you get airway collapse. And so an obstructed nose increases the amount of airway collapse that happens, and it makes it easier for that airway to collapse. And so instead of not breathing at all when your airway collapses from your nasal breathing, we start breathing through our nose. The problem, or sorry, start breathing through our mouth. And the problem with breathing through your mouth is that it increases the airway resistance. And why does that happen? Well, when we open our mouths, our jaw, it's on a hinge and it drops down, our jaw drops down, but it also drops backwards and that pushes the tongue backwards and crowds the air space. And so we get more airway resistance, and that because that decreased diameter of the airway behind the tongue in the retroglossal space. There's also, and that leads to increased oscillation because air has to flow through that narrowed space faster. With faster airflow, you get a decrease in pressure in the intraluminal space, and that leads to vibration of that airway, sort of like if you had a garden hose and you kind of pinched it off, it would start making noises. That's the same thing that happens with snoring. It's just air is making the walls vibrate because the air is moving so quickly through that space. Nasal ventilation reflex. So you do have these reflexes that are important with your nose. One of them is the nasal ventilation reflex. When you look at people that breathe through their nose versus their mouth, if you breathe through your nose, you actually have an increase in the minute ventilation and increase in the tidal volume. And we know this because we did the study back in the 80s where we anesthetized a bunch of people's noses and looked at their tidal volumes and their minute ventilation and found that if you anesthetized noses, people tended to breathe less. There's another reflex called the negative pressure reflex. And this is, when you breathe through your nose, there's a reflex that happens that tightens the genioglossus muscles in your airway and makes the airway more stiff. This was another study that was done in the early 90s. What they did in this study is they had on side A on the left, we have the normal response to a pressure drop. So we have the airway pressure, we have a sudden drop in the airway pressure, and then it kind of returns to normal. And we're looking at the genioglossus EMG signal. And what we see is that the genioglossus signal, when you have that pressure drop, there's this reflex to like tighten up the airway. Okay. So it's called a negative pressure reflex. When you anesthetize noses and you do the same thing, that genioglossus EMG signal is greatly blunted. Okay, and so this is some evidence that this negative pressure reflex is really important in keeping our airway open. And I also point out, like when you're breathing through your mouth, like you're not really benefiting from this particular reflex. By the way, this is like one of those reflexes that we see that are blunted when people drink alcohol, which is why one of the reasons why alcohol tends to make sleep worse and to make sleep apnea worse in particular. And then finally, we have nitric oxide. So nitric oxide is made in the nose and the sinuses. It is an aerotransmitter that acts between your nose and sinuses and your lungs. It is a very potent lung vasodilator. It reduces VQ mismatch, improves oxygenation in your blood. And it seems to have a role in maintaining muscle tone in the pharyngeal muscles. Obviously not the only thing, but it is important. So let's kind of look at noses. If you're not in the habit as a sleep doctor of looking at noses, I'm going to encourage you to like spend the next few clinic days that you have just paying attention to what their patients' noses look like. Narrow noses are narrow on the inside, and wide noses are wide on the inside, or wide on the inside. So when you have a wide nose, I think about turbinate hypertrophy because it's making the nose bigger. People that have really narrow slit-like nostrils, they tend to have what's called narrowing of the nasal valves. And then finally, look for like crooked noses or really a lot of asymmetry in the nose. That can be due to trauma or just how their nose is. That nasal septal deviation can often be a source of nasal obstruction that may need to be corrected. And that's where we get our ENTs. I got these pictures from one of my ENT friends. So I'm grateful to my friend, Dr. Paula Jackson, for providing these to me. And then on the bottom right corner, you see this guy, his nostrils are asymmetric, but they're asymmetric in a very special way. So the left side seems to be kind of almost collapsing here. Okay. And we have a better picture of it here. So this is external nasal valve collapse. On the inside of your nose, there are these little folds of skin, and there's actually two sets. There's an external, and then up near the nasal alar sulcus, a little bit higher on your nose, there is an internal valve. So there's an external nasal valve and an internal nasal valve. These are some of the most narrow parts of your airway. And the cartilage of the ala nasi, that wing of your nose, it's supposed to stay open when you breathe in. So when you breathe in, the pressure just inside your nostrils drops. Okay. And you can kind of test this out for yourself. You can feel it or look in the mirror, all you do is just lean back and take a deep breath in, and you'll feel like, you can see the wings of the nose, the ala nasi, they'll kind of collapse a little bit. If you have external nasal valve collapse, they're going to collapse all the way. You won't be able to do this. This is a problem where the cartilage has become weak in the the ala nasi, and that requires surgery too. The facial ENT doctors will do this work where they kind of take some cartilage and sort of stiffen that ala nasi up so it doesn't collapse when people are breathing in. This is a big problem in sleep. I didn't really pay attention to this when I was just an allergist. I became a sleep doctor after I was an allergist for a few years. I did not start paying attention to this till I became a sleep doctor because it was so important that my patients breathe through their nose when they're using CPAP that like this became a problem and I needed to address it. So if you see this kind of thing, get these patients to your ENT colleagues. They will be able to help these patients and improve their ability to breathe through their nose dramatically. The only other thing I have to say about this is that when I see this kind of thing, I have a tendency to want to use nasal pillows as the kind of CPAP mask for these patients, just because the nasal pillows will kind of help prop open the ala nasi. And so that's a consideration when you see this. And so if you ask me why a sleep doctor needs to look at the noses and look for this, that's one big reason, because it'll help you help that patient pick the right mask. They also make these like breathe right strips. So the breathe right strips come into play. There's these things called, this is Oxyade. This is like a wire. It has these silicone tips on it. And it kind of like goes in your nose and it kind of helps prop open both the external and internal valves of your nose. And then this other product, I've seen this one too. It's Mute, this little plastic rings that also go in the nose. And again, these are all like sort of temporizing measures to help hold the nose open so that when you're breathing, you can breathe effectively. When you're seeing children in particular, but even adults, I look for adenoidal face. So one thing I do in my clinic is I'll just watch my patient and see how they're breathing. Do I see this person with this patient has an open mouth all the time? Are they always breathing through their mouth? And we look for these things. These 5 pictures, these children obviously came from much different parents, but they all kind of look the same, right? They have this sort of similarity. They all have their open mouth. They have this sort of, their upper lip is elevated a little bit. This is a really common thing because with chronic mouth breathing, you have to kind of like tighten up these muscles that elevate your lip, these lip elevating muscles. The ala sulci are this little fold around the edge of the nose. You can see it's really flat, especially in this little boy right here in the top middle. And they're kind of tired too. And you're tired because you can't breathe effectively and you just have a lot of trouble getting good sleep. So what are the consequences of this? So if you keep breathing through your mouth all the time, so if you have chronic nasal obstruction, one thing that happens is you get caudal growth in the maxilla, and that's where that high arch palate comes from. Maybe it's better to say that the teeth are too low, not that the palate's too high, right? You get this caudal growth of the maxilla is because your mouth is open too much, and it changes which muscles are activated in your face, and that leads to this caudal growth of the maxilla. This has a lot of implications for orthodontics in particular. You can get some significant problems, including crossbite and things like that. And we know this because we've done this experiments back in the 70s in monkeys. So this study, I really like this study. It's really interesting. These researchers back in the 70s, and I think it's referenced at the end of the paper if you want to see it. What they did is they had these rhesus monkeys, and when they were babies, they put these cone-shaped silicone plugs in their nose, and they kind of stitched them into place. So the monkeys could breathe out, but it acted like a one-way valve. They couldn't breathe in through their nose, so they were really forced to breathe through their mouth, and they just left them there and monitored these monkeys. So this is a normal rhesus monkey face. So we have the sort of flat lips, and this is a normal rhesus monkey tongue. And I'm sorry about the quality of the pictures. This is the best I could find. This is I had to hunt this paper down. It took a while for my librarian to find it. But this is a normal monkey tongue. And then when you plug up noses and you leave them plugged up in these rhesus monkeys, what we find are a few things. We find this sort of lip elevation. So their lip, instead of being kind of straight across, we get this lip elevation, which is a lot like that lip elevation I just showed you when those 5 children. And then they get all kinds of crossbite and overbite and underbite, all kinds of issues with their teeth are part of this. They also develop these sort of strategies to humidify air. One of them is to like they kind of stick their tongue out and they have this sort of V-shaped tongue, and they'll even develop a little groove there. Other monkeys develop two breathing channels, like here in the middle bottom. So we have two breathing channels. And I think the top one here, B, actually developed three breathing channels to humidify air. So these monkeys develop these different strategies to humidify their air when they can't breathe through their nose. But a lot of it leads to a lot of the same kind of problems that we see in children that have chronic oral breathing. Okay, so I'm just going to shift gears a little bit. This is one of my favorite allergy slides, and I like this slide because when we talk about rhinitis, it's not really just the nose. Allergic rhinitis affects, first, it affects eyes. In fact, allergic conjunctivitis is sometimes much more bothersome to my patients than the allergic rhinitis is. Because they can't stop rubbing their eyes. The typical thing is a child or an adult, every time they go outside in the spring, summer, or fall, their eyes, after about 5 or 10 minutes of being outside, they just start rubbing their eyes and itching a lot, and their nose might start running too. So we have a few findings, and these are really easy things to see in clinic. So when you're looking at your patient, and after you've done your Mallampati score, and you're wondering what other physical exam things you should write down, this are some things you should point out. If you see them, look for them. The first on the top left here, we have what's called Denny lines. It's these little folds of the lower eyelids, and it's from venous congestion. It's from excess blood flow to the conjunctiva because of the chronic allergic conjunctivitis that these patients have. You also get what's called allergic shiners, so these dark circles under the eyes. And again, there's extra blood flow to the eyes and the conjunctiva, and that's why you see this. There's also extra blood flow to the nose that's causing this. In the middle, we have a little boy doing what's called the allergic salute. So this is this move where you wipe your nose up. And so when you see patients wiping, especially little kids who, are not thinking about how they look at it in public, they'll do this anytime. And when you see children doing that, think about chronic rhinitis. You need to start asking questions about that. If you do this enough, you can see he's creased his nose here, and that crease, you can actually get a little crease in your nose. It's called the nasal crease, and this is something that I look for in almost every single patient I see because it's right there. It's on their nose. It tends to be easier. It's really a fate in this person because he's kind of fair skinned. The darker your skin is, the easier it is to see this nasal crease. And then once you start seeing them, you're going to see them everywhere because you're going to be looking at people's faces and say, this person has been wiping their nose quite often. Eczema, it goes along with rhinitis. It's atopic dermatitis. And so where do we see atopic dermatitis? In the flexural creases, like on behind the knees, but also in the antecubital fossa inside the elbows. And then on the face too, especially in babies. That's a really common place. That's a really common place to get eczema is on the face. And here we have more conjunctival injection here. So it's not, there's only two pictures here that have anything to do with the nose. Like I always really pay attention to these other things. And these are all good clues that there's problems with rhinitis and perhaps allergic rhinitis. Some symptoms of nasal obstruction, difficulty breathing through one or both sides of the nose. One of the things I ask about is, do these patients have alternating nasal obstruction or is it fixed? If it's a fixed nasal obstruction, like a patient that says, I can always breathe through my left, or most of the time I can breathe through my left side of the nose, but I can never breathe through my right side of my nose, suggests that there's a structural problem there. There's several reasons why you can have that nasal obstruction, but that if it's alternating, that suggests that it's inflammatory in nature, and that will shift. I will also tell you that there are some reflexes in the nose. One is if you're lying down, because of the rostral shift in fluids as we lay down to sleep, there tends to be a little bit more nasal congestion at night and in the morning than the rest of the day. So there's a little more fluid in the nose. And if there's also dependent nasal obstruction. So if you lay down on your left side, then the left side of your nose will tend to get slightly more congestion and more difficult to breathe through, and the right side will get easier to breathe through, and then the opposite is true too. You lie on your right side, the right side of your nose is down, and it'll be more congestion on the right and less on the left. General nasal congestion, though, is another clue, obviously. Rhinorrhea. I kind of talked about the supine positioning. Recurrent sinus infections, itching and burning eyes are like a huge clue, especially for allergic rhinitis. I use that as a quick way to understand if my patient is mostly an allergic rhinitis patient or a non-allergic rhinitis patient. Non-allergic rhinitis, they don't really have eye symptoms. The allergy patients almost always have eye symptoms. And finally, looking for medical treatment. This is a slide. I got this from a ENT textbook. So, as expected, that ENT doctor likes to divide everything into things that they can do surgery on and things that they can't do surgery on. So we have structural problems on the left and we have inflammatory problems on the right. There are many of them. When I think about structural problems, especially fixed problems, I think about nasal polyps in particular, which are very common. I think about deviated nasal septums, which are very common. And then different kinds of hypertrophy of the turbinates. And there's some special forms of that. There's this thing where you can have a sinus inside one of your turbinates called concha bullosa, and it makes the turbinate really big and really obstructed. Those often get removed. And then on the right side, we have things like allergic rhinitis, but because I'm an allergist and everybody assumes that it's allergies, I also get to diagnose lots of other things, like especially vasomotor rhinitis. Vasomotor rhinitis occurs it's typically in older adults. Adult onset is a really common part of this, but the big thing is that it's not going outside that bothers them or being around dogs or cats or something like that. It smells. The smells this causes a reflex in your nose that leads to a lot of mucus production. So these patients have trouble going to like Bath and Body Works or candles bother them, perfumes definitely bother them, smoke is absolutely a trigger for this. And these things, when they smell these things, their nose will start running. There's a form of this called gustatory rhinitis, which is also really common. In gustatory rhinitis, you smell food, and when the smell of the food while you're eating it can trigger the rhinorrhea in the nose. So these patients will often cough, have postnasal drip symptoms, have a globus sensation after they eat. Those are common symptoms of gustatory rhinitis. I point those out because, I practice allergy, and I'll tell you, these two problems at the top are way up on the list of things that can cause inflammatory problems in the nose. There's other things, but they're less common. Okay. Hold a second. There we go. Okay. Yeah. Okay. So intranasal steroids in sleep. So intranasal steroids are considered an adjunctive treatment for sleep apnea, and you certainly can use this. So if you have someone with very, very mild sleep apnea, when I see those patients in my clinic, one of the things I ask them about is nasal congestion, because if untreated nasal congestion is present, often treating with a nasal steroid like fluticasone, budesonide, there's several of them, that can be very helpful and may be enough for them. Nasal steroids are effective for both allergic and non-allergic rhinitis. Yes, I prescribe a lot of these. I actually prescribe more of these things in my sleep clinic than I do in my allergy clinic, because most of the time when patients get to me in my allergy clinic, someone's already tried this. The primary care doctor's already attempted to use this medicine. Nasal steroids will decrease nasal congestion, they decrease rhinorrhea, and they decrease postnasal drip. Side effects, the big ones are like dryness. So nasal steroids are really good at drying out your nose, and a dry nose can be just as uncomfortable as a very wet nose. So we want to aim for the Goldilocks level in the middle. You can absolutely get a little bit of nosebleeds, not so much frank nosebleeds, but like blood-tinged mucus with the use of nasal steroids. And you can also get nasal ulcers and septal perforation in the nose. So one thing I always tell my patients when I'm prescribing these medicines is that they need to put the nozzle of the nasal spray in the left nostril and point it at the left ear and spray, and then put it in the right nostril and point it at the right ear and spray, and that helps keep them from spraying it directly on the septum, which can potentially cause a perforation. Nasal steroids might decrease AHI, so let's talk about that. This is a study, probably one of the better studies, looking at this question about nasal steroids. So they used fluticasone nasal spray. This is a pediatric study from 2001. And they had these two fairly comparable groups. They just put one on fluticasone and put the other one on placebo. And they looked at pre-treatment and post-treatment. I want to say they treated for about 6 weeks or so. And they saw a pretty decent improvement. The apnea-hypopnea index in the treatment group in fluticasone decreased from 10 to about 5 or 6. which is pretty good, right? If you think about our other treatments that we use, and the definition of like a cure for many surgeries for sleep apnea, it's about a 50% reduction. So this is pretty good. The placebo group did not improve, and there was a statistically significant difference in these two groups. This is another study, and this one was another pediatric study. They had a group of patients, and they just treated them for 2 weeks with nasal budesonide. Their apnea-hypopnea index at the beginning was about 5, and then it dropped down to about 3. So there is some improvement, modest improvement. This is not CPAP, right? Our gold standard for treatment, but yes, it absolutely can help them. I think of nasal steroids as helping my patients use CPAP. If you have patients that are having difficulty using CPAP, it's one of the first things I kind of address with them. What about adults? So in 2004, the study was done. It was published in Thorax. They had 23 patients. It was a double-blind, placebo-controlled crossover trial. They had patients that had an AHI greater than 10. They called that the apnea group. And then they had the group with the AHI less than 10. They called that their snoring group. And what they did is they treated them with fluticasone or placebo, and then they crossed over. And what they found was that the AHI and the nasal airway resistance, so the resistance to airflow in the nose, decreased significantly for both the sleep apnea population and for the total population. And if you look down here, the F stands for fluticasone use, and then this is placebo use, the P. And we have a total population. We have our apneic scores, so people with AHI more than 10, and then our quote unquote non-apneic snorers that had a AHI less than 10. They actually had, I think in their placebo, while they were on the placebo group in the non-apneic snorers, their AHI was around 5, and then with fluticasone use, it went down to about 2.7. For the total population, we saw that similar, like not quite, but close to 50% improvement. And then the nasal airway resistance improved in both groups. And then this is one of the figures from that study, and you can see that the AHI, not for everybody, but for some of the patients, it improved dramatically. All right, Afrin. So we all know Afrin, and Afrin is an adrenergic. It is a non-selective agonist on alpha-1 and alpha-2 receptors. It's particularly important in the nose for the alpha-1 receptors were particularly important in the nose, and it causes vasoconstriction in the nasal vascular beds. The onset, I don't know if anybody's ever used this before, it works great. It makes it really easy to breathe through your nose really fast. Onset of action is like 5 or 10 minutes. It lasts several hours, and then it kind of wears off. But you can get this thing called rhinitis medicamentosa. And so how does that happen? So without Afrin, you have naturally occurring your catecholamines in your body act on these nasal alpha-1 receptors, and they cause vasoconstriction. So they limit your natural catecholamines limit the amount of blood flow to your nose. When you spray Afrin in your nose, you're kind of blasting all these alpha-1 receptors a lot, and it makes the airway it causes a lot of vasoconstriction. That's why it feels so good and it's easy to breathe all of a sudden, right? But with chronic use, what will happen is that you get internalization of these alpha receptors. So like lots of things in our bodies, if you stimulate these receptors too much, they're going to get internalized. They like downregulate these receptors, and then they're not there for your natural occurring catecholamines to act on, and you get nasal vasodilation, and that leads to all kinds of problems, a lot of nasal congestion, and also they can get some histologic nasal mucosal changes, and particularly you'll get more mucus production with the chronic oxymetazoline use. So what's the solution? You use more of it, right? So the patient uses more, and they kind of ratchet up how much they're using in order to get some kind of relief from all this nasal congestion that they have. You have to intervene, right? Fortunately, we have great ways to intervene. So steroids tend to help upregulate these receptors. So a combination of stopping the Afrin and then using something like fluticasone, that will resolve this particular problem. Sorry. Okay. So another question is, well, how much is too much, right? So how much oxymetazoline can you get away with and not get rhinitis medicamentosa? So I have 3 studies to talk about. One is, so first of all, one spray is 100 micrograms when it comes to Afrin, pretty universally. there was one of these studies, the first one from 2010, and I'm not going to try to say this author's name, but they found 14 days of oxymetazoline, 200 micrograms, so 2 sprays each nostril 3 times a day, will in fact cause rhinitis medicamentosa. So that's bad. You don't want to do that. And that's in normal subjects. The second study by Dr. Baruti is an ENT doctor who's written a lot about rhinitis. They found that 28 days of 200 micrograms once daily did not cause rhinitis, but that was in allergic rhinitis patients. So that's kind of interesting. Maybe there's something different about those allergic rhinitis patients. And then finally, this third study, it was kind of a strange one, but I threw it in here because I think it speaks to the uncertainty on this. 28 days, 200 micrograms, 3 times a day, did not develop rhinitis medicamentosa, and that was a normal study. So we have some it's not entirely clear how much is too much. So Dr. Bruti's paper, I personally have found this paper to be quite influential. I was in allergy fellowship when this came out, and it changed the way I felt about Afrin. So we have 4 groups: placebo, fluticasone, oxymetazoline, Afrin, and then both fluticasone and oxymetazoline. And what they were looking at is the nasal peak inspiratory flow. Our pulmonologist might be familiar with this measure, and we just measure how fast how much flow can you generate through your nose when we were using one of these treatments. And what they found, so I want you to pay attention to these black circles. So the black circles, we see improvement in the nasal peak inspiratory flow as time goes on. And then this is the washout period. And when they stopped using the fluticasone and oxymetazoline, you would think, well, oxymetazoline, there's a lot of oxymetazoline, maybe it's going to cause rhinitis medicamentosa, and it turned out it really didn't. So it seemed from this paper that fluticasone was protective against rhinitis medicamentosa. We also know, and this is one of the other studies I mentioned earlier, the fluticasone, like if you do develop rhinitis medicamentosa, in this study, they purposely induced it to see how fluticasone would treat it. And what they found was within 3 days, the patient's peak nasal inspiratory flow, their nasal airway resistance, all these things basically returned close to normal. And it only took a few days. So I don't want you to be too afraid. I think Afrin, oxymetazoline needs to be treated with respect, but you can use the drug if you feel like you need it. Okay. What about alpha agonist and treating sleep apnea? So I have a short answer, which is that it's not enough to matter. The long answer is that this was a 12-patient study. They did a randomized placebo-controlled crossover trial. All the patients had fairly severe sleep apnea, and they used xylometazoline. This is a drug that is not available in the United States. It is available in Europe. It is an alpha agonist, almost exactly like oxymetazoline. And they used xylometazoline for a week. Then they did a PSG, they did nasal conductance, they did symptom score. What they found is that the AHI decreased for about 210 minutes after the application of the xylometazoline, but it didn't decrease that much. It was like a little bit of a decrease, but not very much. There was no change in their Epworth scores. There's no change in sleep quality or sleep latency in this group of patients. So I would not use this to treat nasal congestion alone in my patients. This is another study. This was from 2005, and they had 10 patients. They used oxymetazoline in this particular study. 10 patients with untreated sleep apnea and nasal obstruction, and they did a single-blind placebo-controlled crossover study. 200 micrograms of oxymetazoline at the start of the PSG, and then 4 hours later, they gave more oxymetazoline, and they used a breathe-right strip that kind of propped the nose open. They did posterior rhinometry, so they measured pressure in the nose, and they did a PSG. One thing they found in this group, they all had severe sleep apnea, and that there was about a decrease by about a third in their AHI with this particular treatment. This group actually saw improved sleep efficiency and even increased N3 and REM sleep, probably because their AHI was marginally improved. There are other drugs we can use. One is chromones. So these are older drugs. I think they first got them in the 40s, and then in the 50s and 60s, this was especially in the 50s and 60s, they were using this to treat asthma. Chromones are really safe. They work quickly. they don't last very long. So one of the reasons we don't use cromolyn, like inhaled cromolyn, is because it doesn't last very long. You have to use this inhaled thing like twice, 3 or 4 times a day. And I've been told that there's a spacer that's about the size of a 2-liter Coke bottle. It didn't work very well. But this drug is useful, and I use it in allergy. I use it particularly when patients are in situations where they have these unavoidable nasal congestion triggers. The classic is they're going to grandma's house, the kid's allergic to the cats, where they use the nasal preparation of cromolyn and the eye drop version of cromolyn to kind of control symptoms while they're visiting grandma for a few hours. So uncommon environments, things like that, that's when I like to use this particular medicine. We also have ipratropium nasal spray. This only treats rhinorrhea. It does not treat nasal congestion, so it's not going to make a huge difference for our patients, but I bring it up because we use it for that gustatory rhinitis problem. We use it a lot in allergy to treat that particular problem. It also is it might be the only drug that has an indication for the treatment of upper respiratory tract infections at the 0.06% concentration. And it's the attribute you know and love from pulmonology. So. Okay, and then azolastine. Azolastine is along with some sort of nasal steroid, is one of my go-to drugs to treat nasal congestion in patients and rhinorrhea. It is an H1 receptor agonist, so this is our inverse agonist. So this is like Benadryl, like Allegra, Claritin, Zyrtec, but we spray it in your nose. When we spray the azolastine in your nose, we get the local concentrations of antihistamines very, very high, about 10 times higher than what we would if we just gave you a pill of Zyrtec or Allegra. When we do that, it will help with seasonal allergic rhinitis, but it actually treats vasomotor rhinitis. And it does that because there are histamine receptors on the neurons in your nose, and it slows neural transmission inside your nose and helps inhibit that nasal reflex that leads to vasomotor rhinitis. So I use it for vasomotor rhinitis pretty much 100% of the time. I think this is like one of the go-to drugs, this plus a nasal steroid. And the nasal steroids, because they work together to help control symptoms for those patients. Biggest side effect, you can get sedation, although I almost never hear patients complaining about that, but the bitter taste does taste bitter. It's one of the preservatives in the medicine. They make a low preservative version of it, but it's really expensive, so most people just put up with the taste for about 5 minutes after they use it. I always tell my patients that's how you know it got in your nose. In 2000, there was this, there's been a few studies. This one was helpful. It showed improvement in rhinorrhea, but doesn't really improve daytime somnolence. So it doesn't improve daytime sleepiness in this group of patients that had daytime sleepiness at the beginning of the study. And it didn't really improve nasal congestion. But for runny nose, for that vasomotor rhinitis thing, or noses running because patients allergic to cats or dogs or something, this is a really helpful medication. Other allergy treatments and related to sleep. Montelukast is a leukotriene antagonist. There's very little data on its use in sleep apnea. We use it to treat both allergic rhinitis and asthma. Our pulmonologists are probably really familiar with this drug. Fun fact, or not so fun fact about this drug is that it causes nightmares in patients. So it's one of the few drugs that actually cause that, and that can be a real problem. In fact, it has a warning on the label for that. Antihistamines treat rhinorrhea pretty well, but they don't really have a huge effect on nasal congestion. To treat nasal congestion, you really need like a nasal steroid, honestly. And then there's allergy shots, which decrease people's sensitization to airborne allergens. I don't know if any. I looked again last week to look to see if anybody had published anything about it. I have not seen anything about how allergy shots affect sleep apnea. If someone's aware of an article like that, I would love to read it. Okay, so in summary, our nasal obstruction is one of those reasons why patients have fragmented sleep or cannot use CPAP. You have to be able to breathe through your nose to use CPAP. And as we all know, nasal obstruction is one of those biggest reasons why people can't use CPAP. It is necessary for that use of CPAP. And the nasal obstruction can lead to unstable or ineffective breathing during sleep.
Can go to what?
And finally, if you treat the nasal obstruction, then you can often correct a lot of oral breathing, and that's going to improve your patient's sleep and their daytime function also. And finally, remember, if you're going to treat with anything, use intranasal steroids. That would be the treatment of choice for nasal congestion related to sleep apnea. Look out for those structural problems where you need to send them to the ear, nose, and throat doctor to help those patients. This is my bibliography. And then I guess we'll take questions now. So, uh,
Yeah, thank you for talking about this important topic that we see in sleep clinic all the time. It looks like Dr. Stuart Men has a question for you. Do you make a distinction between patients who are mouth breathers both day and night as opposed to nose breathers during the day and mouth breathers only at night, especially in terms of recommending the type of mask that they should use with CPAP?
Uh, my experience with using CPAP with my patients is that the full face mask is nice. And yeah, you could use that in someone that has problems with nasal obstruction, but they're never really going to be happy with breathing through their mouth with their CPAP. One, we know about reverse apnea, right? Reverse sleep apnea, where the breathing through your mouth while using CPAP can actually make the sleep apnea worse. Two, like it dries your mouth out. I think noses are really good at humidifying air. Mouths are not as good. And waking up with a dry, like a bone dry mouth every night because your mouth is open, you've been breathing with through your mouth while using CPAP is very uncomfortable. And I think it discourages a lot of patients. I don't really make do I make a distinction between them? Not really. No, I will tell you that there is a circadian rhythm to your nose, just like there's a circadian rhythm to lots of our bodily functions, and there tends to be more nasal congestion at night in general for most people, and less during the day. So I kind of lump everybody together. When I'm in sleep clinic, we're really, really focused on their sleep. When I'm in my allergy clinic, I guess I have a more holistic view about like all their daytime function too, and how their nasal congestion is affecting that.
You spoke a lot about the different nasal sprays that you can use. Some patients use like the neti potty and like the saline sprays. Do you have any thoughts on those?
Yeah, sorry, I left it off. It was just I had to cut the slide. I had to cut something. Sorry. The saline is great. There's no problem with it. Obviously, it doesn't have like a pharmacologic function, but it does make your nose more comfortable. And especially if you're using a lot of nasal steroids that dry your nose out, and the azolastine, which dries your nose out, adding nasal saline can make their nose feel a little more comfortable. And I always tell my patients there's no limit to how much saline you want to put in your nose. Like that's up to you. We use not neti pots so much, but there's a squeeze bottle. There's a company called Neilmed that makes one that probably the most common one I've ever seen. You can buy them over the counter, anywhere. And it's a squeeze bottle with these salt packets. They got to use distilled water in there. They got to warm that water up. Using cold water in your nose is super uncomfortable. Never try this. And then when you use the squeeze bottle in the nose, the one thing you need to tell the patient is that they need to close their soft palate. How do you close your soft palate? You breathe out slowly through your pursed lips like you're blowing out birthday candles, and that will close your soft palate, right? So just like that. Okay. So I have my patients fill up their little saline bottle, put the salt in there, and then lean over the sink, put it firmly in one nostril, squeeze gently while they're blowing out through pursed lips, and that will keep the saline in their nose. If they don't do that, they were going to choke themselves on saline, and they will not do that ever again. So you really have to tell them that the first time, please do that. So I have to talk people into it over and over again because they tried it and failed horribly and had a terrible experience. I have to tell them like, okay, let's try it the right way first. So
It sounds like definitely a good tip to give. Um, does anybody have any other questions? You can unmute yourself as well if you like. You talked about how the nose is important in terms of like obstruction and obstructive sleep apnea. Is there any data about the nose and central sleep apnea?
that I've really seen. No, no, I'm not aware of anything like that. It's easy one. All right.
Hi, this is Ian Weir. How you doing? I'm calling
How you
from.
doing?
Thanks for a great talk. I think it's really important topic in sleep medicine and try to emphasize to our fellows to examine the nose when they see new patients. I think that's important. We were just talking about this morning in sleep clinic a recent pediatric study that looked at nasal steroids versus just nasal saline in kids. It came out in JAMA Pediatrics. and they were just looking at symptoms, and they found that it was equal in reducing symptoms. How do you think nasal saline by itself is gonna like treat sleep apnea? Because it was a randomized controlled trial. I can leave the link here in JAMA Pediatrics, and I don't believe they had PSG data, but it was in Australia, and they were following symptoms, and they found that these kids from 2 to 10 or so had a pretty significant reduction in symptoms. I think a third of the kids had reduction in symptoms of snoring and sleepiness and a few other things at 6 weeks, and then another third had approximately after another 6 weeks. So how would just nasal saline by itself kind of help pediatric sleep apnea? What do you think about that?
Think I would use both, and I have used both. When I think about nasal saline, I think about it, it's like a rinse. Like I call it nasal saline rinse, and I think that's probably the best way to think about it. If you have tons of mucus and dry mucus in your nose, like you can spray all the nasal steroid in there you want. It's not really going to make a huge difference, right? Because that's you're not going to affect that. That stuff has to be washed out. Now your nose has cilia that moves things around, and eventually it'll kind of get rid of it. But like if you want to speed that process up, the nasal saline would by far be my choice. If the problem is inflammation and that's the biggest issue, the nasal steroids are probably going to do a better job. And that's how I kind of think about it. Does that make sense?
Yeah, no,
Yeah.
absolutely.
Yeah.
One other quick question, if not, maybe not so great for nasal obstruction, but we've been seeing more people using mouth tape and basically kind of forcing them to breathe through the nose. And
Yeah.
there's been some data for mild sleep apnea in adults that it could be helpful. I've actually started to recommend that in some patients, and I've done some repeat sleep studies, and I've had every patient get better with the mouth tape. So what do you think about mouth tape? Obviously, if they have a very severe nasal obstruction, it's going to probably be difficult for them to use. But if they have mild nasal congestion or mild sleep apnea, have you seen any effects with mouth tape?
Recommended mouth tape to 4 patients this morning. I use it constantly in my sleep clinic. I never talk about an allergy, but in sleep, absolutely. Why? Well, you got to keep your mouth closed, right? Like the way nasal CPAP works in particular is that your soft palate is supposed to be firmly pushed down against the back of your tongue. And if your mouth is open, that's not going to happen. And all that air that we want to pressurize your airway is now just leaking out your mouth. Like, I think it's actually really crucial to keep your mouth closed. And I tell my patients this, like, we have to keep your mouth closed. Chin straps and mouth tape. I mean, I think you got to pick one. If you're having problems with dry mouth with CPAP, that's the first thing I tell them to do. It's like the reason your mouth is dry is because you're breathing through your mouth or you're opening your mouth. Either way, we got to keep your mouth shut. Um, the my caveats with and I've learned this from dentists that I've worked with at the Maryland Sleep Society. What those guys do, I think they're the ones that actually started doing this. I'm not sure I ever heard about this from sleep doctors until I started hearing it from dentists. Um, One, don't use it if you're nauseous. Two, like you need to use like either medical tape or they have these special tapes that you can buy. You can look online and find them. So this oval black stretchy tape. Those are like what you would use. You need to be able to open your mouth. Like if you coughed, your mouth should pop open and that tape should separate really quickly. And I feel like if that doesn't happen, that tape is too strong and you need to use less of it or some other tape. I like it though. I like it a lot. Because they can breathe through their mouth, their nose. Also, I've used it in patients that like for snoring. In fact, I had a patient today, he didn't have sleep apnea, but he snored a lot. He asked me what he could do. And I'm like, well, maybe you could try this because we know snoring gets worse when you breathe through your mouth. And if he's able to breathe through his nose, he doesn't seem to have nasal congestion or nasal obstruction. Yeah, the mouth tip would work.
Thank you.
Yeah. I think we need like big mouth tape to come up with a research project to show us because I think you're right, like about the mild sleep apnea. I bet there's some improvement there, but I've just never seen a study about that. Yeah, the black stretchy tape, if you just look online, it's kind of oval shaped. There's a brand called Hostage Tape. I do not endorse them, but like they have a fun name and a fun picture online. But there's other companies that make the same stuff. I think it's like a commodity thing where they just buy the tape and rebrand it. But it's this black, stretchy oval tape. It's not very sticky. I've used it myself. It's not bad at all. And the other thing is you can get like skin irritation from the tape around your mouth. And so that's something else to keep in mind if you do this.
Thank you so much. That was amazing. I really appreciate you coming and giving us this talk, and I think we can wrap up here and we'll see everybody again next time.
Thanks.
Thank
Thank
you.
you all for the opportunity. Appreciate it.